Thank you. Well, good morning, everyone. So as Dr. Bold mentioned, I am going to be talking about survival after surgery this morning, and specifically talking about the concept that we all know as cherry picking, and how we can really separate correlation from causation in terms of surgery and survival. So my only disclosure is that I am one of the MCRTP scholars, and it's a program that I highly recommend to anyone considering learning and gaining more skill in the area of clinical research. So cherry picking. So ignoring real patients in favor of those that will give you the results that you want. Okay? Now some of us would argue this is something we do every day as surgeons. And that's really what I'm going to talk about today, is the surgical decision-making process, how we go through it, what it means, and the areas of improvement that can be made in those areas to help us make really good decisions for our patients. So typically, Grand Rounds follows M&M. And M&M is a time where we think about the decisions we make in the care of our patients, right? We talk about the pre-op testing that was ordered, we talk about intraoperative decision-making, and we talk about decision-making in the post-operative setting. So it's really all about decision-making. And I would argue that all of us, even though this is from the STS Code of Ethics, I would argue that all of us really are bound by this type of Code of Ethics, where we need to use our best efforts to protect patients from harm by recommending and providing care that maximizes anticipated benefits and minimizes harm. Okay, so we all have this goal of trying to do the best thing for our patients, whether it's optimizing survival for cancer patients or optimizing quality of life for patients with disabling symptoms from their disease. So this morning we're going to talk about a few things. We're going to talk about selection bias. We're going to talk about the relationship between surgery and survival. And then we're going to discuss the relationship between correlation and causation. And also we're going to talk about creating a mechanism to assess the effect of surgery on survival. So let's get started with selection bias. So when we're making our surgical decisions, we want to be accurate, okay? We want to make the best decision for our patient to, again, maximize benefit and minimize harm. So accuracy we define as the degree to which a variable represents a true value. So in our context, we're saying we want to make the most accurate decision in terms of a surgical treatment plan for a patient that we can. So accuracy is a function of systematic error, okay? Meaning that there are built-in mechanisms in our decision-making processes that put error into our decisions. So the more error there is, the less accurate your variable is going to be. So the worse your surgical decision is going to be. So there are three types of error that we're going to focus on: observer bias, instrument bias, and subject bias. Okay, so we're going to break these down. So the first one we're going to talk about is observer bias. Does anyone have any idea what I mean by this? Yeah.
You see what you want to see.
Great. That is a great way. What he said was you see what you want to see. So this is a distortion, meaning something that's conscious or unconscious in the perception or the way that something is reported, okay, by the observer. So in our terms, what might this be? Can we give some examples? How do we as surgeons introduce bias? Anyone? All right, so if we report blood pressure and we always have a tendency to round down, that's going to be observer bias, okay? A surgeon who doesn't see patients with blonde hair, that's a significant observer bias, all right? There's no rhyme or reason to that, but the patients with blonde hair are not going to benefit from seeing that surgeon. A doctor who thinks that surgeons hurt people, so never refers his patients for surgery. That's a significant observer bias, okay? And a surgeon who thinks that cancer patients always benefit from surgery, they may over-operate. So there's many ways that surgeons themselves can introduce bias into surgical decision making. All right, so the next one is instrument bias. Anyone have any idea what instrument bias is in this context? No? Okay, so instrument bias results from a faulty function or mechanical instrument. So in the case of surgical decision making, it's going to be either a scale that wasn't calibrated and so always produces faulty readings, or maybe it's an ICU that can't monitor A-lines, right? So therefore you can't use A-lines for your practice, and therefore you have an instrument bias. It may be an operating room that can't handle minimally invasive surgery, or a cancer center without a targeted therapies, or a surgeon who's not comfortable with a specific technique. So these are all examples of instrument bias. And instrument bias is probably, of the three types of error, least involved in the introduction of error into the surgical decision-making process. So our third error type is subject bias. Anyone have any idea here? What is subject bias? So if the surgeons are the observers, the subjects are the patients. So what types of bias do the patients introduce into surgical decision making? Exactly, patients that show up as opposed to the patients who no-show. So it's a distortion of the measurement by the study subject, okay? So there are some popular notions that some patients with breast cancer believe that alcohol is a significant cause of their breast cancer. So they may exaggerate their reporting of alcohol use. Other patients are heavily involved in social media and cancer advocacy. These patients may be more likely to participate in a study about cancer patients, and they may bias that study. Another example would be patients who live close to a cancer center. They may be more willing to participate in a clinical trial than someone who lives 300 miles away. And finally, some patients will believe that no treatment is going to affect their overall course. So why should they have any treatment at all? So those are all types of subject bias that can affect the accuracy of the decisions that we make as surgeons. So again, accuracy and effectiveness of our recommendations are all subject to bias. So our practice in everyday life is all subject to bias. So it affects, as we mentioned, the patients that you see. It affects the patients that end up in your office, okay? As surgeons, we don't have a lot of people just walking into clinic. Typically, people are referred to us. So if there's a lot of bias in the referral process, that is going to directly affect your practice. It also affects, so your internal bias, your observer bias as a surgeon is going to affect the patients to whom you offer surgery. Okay, if you don't believe that the surgery you're offering is really going to help people, you're less inclined to offer that procedure. And then again, the types of surgery, and there's a little bit overlap there. So hopefully now everyone understands what I'm talking about when I talk about surgical selection bias. Any questions about that? Okay, all right. So there are numerous cartoons about selection bias, so I threw a couple of in here. So try to grab that 84, it would look really good in our report. So hopefully we aren't doing this either in our research or in our patient selection. So now we're going to talk a little bit about the relationship between surgery and survival, okay? So I'm going to pause a little bit from the statistics and tell you a little story. So this is a picture of a family from June of 2013. This is a story about a lung cancer patient. Let's have a show of hands. Who is the lung cancer patient? Is it the younger man? Anyone? Okay. The woman next to him? Okay. The man, the older man? Okay. And the young woman? Okay. All right. So I think you guys everyone's getting it. We're stopping the stigma a little bit. Lung cancer is not a disease of old men only. So our patient is Lisa, okay? And I met Lisa in June of 2013, and she had been having persistent shoulder pain. And on workup of her shoulder pain, she had a chest x-ray that demonstrated a large lung mass. She was 59 years old, very, very distant smoking history, and she came to me with a diagnosis of adenocarcinoma needing mediastinal staging. So we staged her mediastinum, and her pathologic stage was designated as stage 3A. She was planned to undergo chemotherapy and radiation to be followed by surgery. So she completed this therapy over the summer, and on her restaging PET CT, she was found to have a femur metastasis. So in September, this is a picture of her hiking with her dog, about 3 days after she found out that she had metastatic lung cancer. Okay, so she goes from stage 3 lung cancer to stage 4, but she is able to maintain her lifestyle, and also, you know, she's got a great smile on her face, just maintained a great outlook on life. So she went on to get radiation to her femur and started treatment with one of the molecular targeted agents, Tarceva. So she maintained treatment on Tarceva. She started it in November of 2013. So in August of 2014, this is her support system completing a fundraiser in up Squaw Mountain for the Tahoe Forest Cancer Center. And this just demonstrates, you know, the support, the optimism, and the hope that Lisa had all throughout her journey. So she did very well, and in January 2015, we decided that she was probably going to be a candidate for surgical resection of her primary tumor because she had disease stability on the Tarceva for more than 12 months. So before we did her operation, she decided she wanted to go to Machu Picchu. So she hiked in Machu Picchu with her limited lung function, but she did great and had a wonderful trip. So this is a picture of Lisa the night before her surgery, and she told me that she was absolutely terrified when she was taking this picture and the day before surgery. So we did a left upper lobectomy for her, and about 10% of her tumor was still viable on pathology. She sent me a card last week reminding me that it was the anniversary of her surgery. So she is now 1 year disease-free. So what happened here? So we have this 59-year-old woman with stage 4 lung cancer. She had chemoradiation to her primary tumor. Then she developed a femur metastasis and had radiation for that. Then she started her targeted therapy and had disease stability. Then we resected her primary tumor. And now she's a year disease-free with stage 4 lung cancer. So is this the norm? No, not at all, right? So we know that lung cancer usually behaves like this. And Lisa should have been in this category, right? 4.2% of patients with Lisa's disease live 5 years, with a median survival time of about 12 to 13 months, okay? So she's beating that. And yes, I'm telling you an anecdote, okay? So this is our NCCN guidelines for stage 4 lung cancer. And as you can see here, the only stage 4s that we are really supposed to be doing surgery for, definitive surgery for right now, are folks with brain or adrenal metastasis. So what in the world? What happened? Did I just go rogue here? Well, maybe we went a little rogue, but we did it with guidance and talking to a lot of people. But we do know that more and more patients are having stories like this to share, okay? So we know this from small case series. So this is one of many case series sort of telling a similar story. So this is a series of about 50 patients, and these patients had between 1 and 3 metastases. All of the sites of disease were treated with local therapy, okay? And the patients did great. So they found that synchronous metastases, that treating everything results in favorable 2-year survival. Now, that's a short survival, but it's likely due to the fact that people wanted to get these results out there, okay? So I think we're gonna see more and more of this in the future. So how do we change this, right? We can't change this with an anecdote, okay? We all know that guidelines are based on high quality, high levels of evidence, of which case reports do not qualify. Okay, so what we set out to sort of start our background data collection to determine what the current treatment trends are and oncologic outcomes in advanced stage lung cancer. So we looked at the California Cancer Registry from 2004 to 2012, and we identified 34,000 patients with advanced stage lung cancer. What we found was that treatment with chemotherapy increased over the study period, and that treatment with surgery or radiation actually decreased over the time frame. So this is what our treatment patterns looked like. So as you can see, a lot of patients are having chemotherapy or chemotherapy and radiation. A few less patients are having radiation only. There's a lot of patients in this no treatment group, okay? So that's probably something that needs more delving into, which we're not really going to talk about today, but that's sort of alarming that the no treatment group is the highest group in terms of our frequencies. And then here in the middle, we see all of our surgical groups, okay? Extremely low. So surgery is not being used heavily in this population. Then we take a look at this. So this is how the trends in the groups changed over the time of the study period. And as you can see, the surgical groups are at the bottom, and they actually went down over time. So fewer patients had surgery over the study period. And again, more patients having chemotherapy and radiation. Now, when we look at survival, we see this, okay? We see that our surgical groups, being the smallest group, they actually had the best survival, okay? The patients who were treated with chemotherapy and chemoradiation, and even the missing group, which is right here, their survival is significantly shorter than the surgical groups. And again, the people who had no treatment or radiation alone, they're in the lowest surviving categories. So how do we put this all together? So we know that very few patients are having surgery in this setting, but the ones that are actually doing quite well in terms of survival. So what do we do with that? Well, we continue to cherry pick and have fewer survivors, or we start to look at the relationship between the patients we cherry picked and survival and see if we can make a little bit more science out of it. So let's talk a little bit about correlation and causation. So, does this mean that surgical management of lung cancer causes longer survival? Does what I just showed you mean that? No, not at all, right? So when we talk about the relationship between predictors and outcomes, they're explained by certain things. So chance. So sure, maybe just it happened that randomly all the people who had surgery in my study were gonna do better anyway, okay? But by having a large sample size, you can minimize the effect of chance. So bias, which we've talked about already extensively, can certainly influence these results, okay? Confounding, which we're gonna talk about in a little bit more detail in just a second, definitely can influence this result. Effect cause and cause and effect certainly can establish a relationship between predictors and outcomes. So this is a blog that was posted last summer talking about how eating chocolate prevents heart disease, okay? And this blog was based on this study from the journal Heart, which was a study of over 20,000 patients that looked at the amount of chocolate that people consumed and their risk factors for cardiovascular disease and their incidence of MI and stroke, okay? And what they found was that the higher compared to lower chocolate group was associated with lower coronary disease and lower stroke rates, okay? So does that mean that eating chocolate prevents an MI? So what they found, so in this study, they propensity matched. So they pulled out subjects that matched on the confounders, the variables that they had established that they wanted to match patients on, and found that this effect went away. So when they were comparing subjects who lined up directly against each other based on variables that they determined, there was no effect of chocolate on cardiovascular disease. Okay? So their conclusions really showed that they added to the literature saying that there's an inverse relationship between chocolate and cardiovascular disease, but there does not appear to be any evidence to say that chocolate should be avoided in those who are concerned about cardiovascular risk. All right? So this is confounding, right? The factors that they matched their patients on, those were really the factors that made the difference between heart disease versus no heart disease. So things like smoking, lifestyle choices, cholesterol, etc., those were the confounders between the chocolate and the cardiovascular disease. So does chocolate prevent MI? Not at all. All right, so but there is a correlation. A correlation meaning there is some relationship between two variables, and a correlation defines the degree of that relationship. Whereas causation is the relationship between a cause and an effect. So how do we define a causative inference? A causal inference? Anyone? Okay, so causation is much more difficult to establish than correlation. It requires several things. One is that you have to have a strong relationship between your two your outcome and your predictor. You've got to have a very high correlation usually, and you have to have a consistent relationship between the two factors. It's got to be a very specific relationship, and it's got to be a time related, okay? So it's got to be something that when A happens, B always happens. And it's got to be something that is biologically plausible, right? It's not plausible that eating chocolate prevents heart disease. That just doesn't make sense from a biologic standpoint. But not smoking preventing lung cancer, certainly that makes sense. So, and you've got to have your causation relationship sort of agree with established biomedical facts. So, do we still think the answer to this question is no? I do. Yeah, I don't think there's any argument to say that operating on someone causes them to have longer survival for lung cancer. But I certainly think we still need to investigate this relationship further. So how do we take this tiny percentage of patients having surgery, but knowing that they survive much longer, how do we take that and make that into meaningful science and potentially change guidelines? Any ideas? All right, so we're going to talk about how we create a mechanism to do that. So it's nice that I followed Soman, and we're going to use big data to solve this problem, okay? And hopefully we're going to use it in the correct way to get a good answer. So we're going to try to separate correlation and causation. So what we're trying to do right now is construct and validate a surgical selection score. And what we want to do with this score is predict the patients who undergo surgery for lung cancer. So there's a lot of data about scoring systems and surgery. Sometimes they're called nomograms, other times they're just called scores. But they're a way to predict certain outcomes based on variables. Now, looking at the literature, you'll see that most of these scores involve predicting survival, okay? Or predicting the success of a treatment. Very few people have actually looked at using selection for treatment in the formulation of a score. So once we have that score, we're going to take the score and assess its relationship to survival and other oncologic outcomes. And we think that we'll see meaningful differences in survival between surgical and non-surgical patients who have similar selection scores. Okay, so maybe some of the patients who ended up in the chemoradiation group would have a good surgical selection score, and maybe, you know, we could hypothesize that their survival would have been impacted differently had they had surgery. So how are we going to do this? So we're using the National Cancer Database, which is a huge data set representing about 70% of the oncologic admissions in this country. And we're going to use Cox proportional regression to develop our score. And again, here our outcome is having surgery. Okay, we're not looking at survival with this score. We're looking at whether or not you had surgery. And we're going to use both clinical and clinical tumor factors and patient demographics to make this score. So we're going to use all the decision points that we use in our practice. So age, gender, other comorbidities, etc. All the things that we think about in clinical practice that affect our decision to operate on patients. So once we have this regression, we will use the significant factors to create our score. Then we're going to validate and calibrate the score. And again, we think that there's going to be a significant relationship between these clinical measures and the selection for having surgery. So the next thing we're going to do is to characterize the relationship between the score and survival. And again, we think that the patients who have a higher score will have longer survival. So then we're going to stratify patients by their score and compare the treatment groups to assess whether or not the effect of surgery is modified by the score. Okay? And again, this is what I was mentioning, that we think that surgery is going to convey a survival advantage overall, but it may not strictly decrease as your survival score decreases. Okay, so where we are now. So the NCDB starts off with 1.5 million patients with lung cancer, okay? And we know that the patients with stage 3A, 3B, or 4 is about 860,000. We know that more than 200,000 patients did not have surgery, chemotherapy, or radiation. Okay, so again, no treatment is fairly high. And then here we can see the breakdown of treatment groups. So again, when we look at the percentage in the NCDB who did not have surgery, it's extremely high, right? The surgical group way down here at the bottom, a very small percent of patients. So here's the breakdown of all of our different treatment groups. And as you can see here, again, the surgical cohort's very small, but it does appear in the NCDB that the surgery groups are getting bigger as time moves forward. So right now we are in the midst of creating the score, so you'll have to hear more about that in the future. But this is what we know. So we know that survival is poor for these patients right now. But we do know that we can see improved survival in some patients who undergo surgery and more aggressive therapy. So what we need to get better at is identifying those patients who may benefit and then implementing those therapies. So it's very important that we remember all the biases that I talked about in the beginning, so that someday we may be able to influence and improve overall survival for lung cancer. So hopefully we can all get away from cherry picking and be a little bit more scientific in our decision making. But I challenge everyone as you go through the rest of your week, think about bias and think about the way that bias influences your practice, influences everyday life and the decisions that you make. Okay, I can't do this research without a huge amount of help, particularly from Bob and all the other members of this collaboration, and especially the MCT RTP program. So thank you all very much. And I'm happy to answer any questions, if there are any. Yeah.
So Elizabeth, in day-to-day runnings of things, sometimes you use best available evidence, although it's not great, to sort of bias how you take care of patients. And so, we're not always going to be able to have unbiased data from ourselves and others to take care of. So sometimes, bias helps you stay out of trouble. So you say, gosh, well, this is a really dumb thing to do.
Right.
I'm not going to do this. It may not be supported by a study that you do. How do you strike that balance? So you find something here in your score, right? So do you think that you'll get to a point where it's like, okay, here's your score, and I'm sorry, or will you see patients and make exceptions kind of on a day-to-day basis? How do you strike that balance?
Well, I think the whole concept behind this score is to provide an answer to that question that you just asked, to take this decision making and apply it to a large population to sort of try to identify some of the more subtle nuances. Because, as surgeons, we get accused of cherry picking all the time, particularly from competing specialties where their survival results may not be equivalent to ours. They say, well, it's just because as surgeons we pick out the healthiest patients who are going to live longer anyway. So really what we're trying to do is conceptualize some of the decisions that we make on a daily basis. And I think, we're all gonna use our intuition, use this score, and certainly, I would say there will be exceptions, to every decision making, and there's always going to be a role for multidisciplinary decision making. I mean, I operated on that patient after multidisciplinary discussion on more than one occasion, because we were not following guideline directed care at that point for her. So I think this score is meant to help decisions be made, but it's not meant to be an absolute end all be all. You have to follow this decision making tree, or you're not going to have good outcomes. So, David.
A great talk.
Thank you.
Elizabeth. The SSS, the surgical survivability score. How do you see that evolving in sort of the era of personalized medicine, where, for instance, can you translate that from an administrative database standpoint to a more genomic-based standpoint, where we identify the patient phenotype, the stage 4 phenotype that doesn't behave like stage 4?
Right.
Because you say intuitively, we've all seen breast cancer stage 4 patients, prostate cancer stage 4 patients who don't behave like stage 4, and there's the same thing in lung cancer.
Exactly. So, I think this comes into sort of recognizing the limitations of the data set with which you're working. So right now we're trying to create this score based on clinical information that you have available at about the patient in the preoperative setting, right? We're not looking at any postoperative variables to create the score. And so I chose the NCDB because right now it's the largest repository we have of that information. And the information that I think that would be helpful to answer your question would be the molecular testing data, which right now is not collected in that administrative database. But what I would say is once we've developed the score, we could validate it using an additional data set that does have that information and see how the molecular testing data affects the score itself. Because I agree with you completely. You know, that's something that is very important for these patients and gives us an idea of how the biology of their disease may impact their survival. So, Bob, did you have something?
Yeah, no, it's great. I just wanted to sort of make a general comment that I think your work illustrates, especially in all the junior people, that when you're designing a research project, it's always good to try and design it so whatever answer you get is a contribution to the literature and addresses sort of an unresolved problem. And I think it also illustrates what Dr. Farmer often says that surgeons are good at asking questions about sort of effects and clinical problems. And you know, here if it is all just correlation, or there is some causative effect, or there's subgroups in between, it'll help kind of resolve what really is sort of a standoff between some surgeons and, I mean, to oversimplify, surgeons and medical oncologists. Medical oncologists say it's all over treatment and selection bias, and surgeons say it's under treatment because there are some patients who need benefit from surgery. So I think that's an important teaching point.
Yeah, and I with each of my planned analyses, you see that I had a hypothesis. I may be wrong, right? The score may not show that surgery really helps more people. So I have to acknowledge that, and I'll still try to publish it, even if I am wrong. So, Doug.
I really like your talk, Elizabeth, but I guess I could comment and get your feeling on this. As cardiothoracic surgeons, we are the most scrutinized group in surgery, probably of all groups, in terms of our outcomes, because of our very robust STS database. And to what extent do you feel that these kind of this kind of scrutiny of our database impacts the way we cherry pick? For example, you don't get your name in the front of the SAC-B if having great outcomes. But again, there's a lot of things in the STS database that don't reflect risk. And now that we're moving towards an outcomes-based reimbursement, how do you think this is going to? Do you think that this could be affect our selection bias in patients?
Yeah, I do. The STS for thoracic does not sort of really measure longitudinal data. They're looking at 30-day and 90-day survival right now, but not much more. So for us on the general thoracic side, the STS database is more of a perioperative outcome measure, which I'm not really looking at with this score. However, I will say that the way that this score and what I am advocating for may sort of run into problems is whether or not what I'm advocating for is truly generalizable to everyone who does thoracic surgery, okay? Because we still know that a fairly substantial percentage of general thoracic surgical operations are done by non-ABTS certified surgeons. And so are the results really going to be equivalent depending on the surgeon? So that's an issue, that we've already run into. Even in discussing some of these patients in a multidisciplinary setting, the tumor board will make a recommendation, hey, let's operate on this patient. And then the patient comes back and says, oh, well, wait, I have this relationship with surgeon so-and-so in my hometown, and I want them to do the operation. Then we say, oh, what do we do now? Is the result that we've advocated for, which was sort of set up based on someone who has, X results, is it really going to have the same outcome in a different hand? So that's probably a little bit more of the concern that I see right now with this. Yes?
So for clinical care, there's kind of two extremes. One's cherry picking, which is really personalized medicine.
Mm-hmm.
Make decisions based on the patient. The other is treating with protocols.
Right.
Protocols, the average, kind of be as safe as possible. So do you feel we should get rid of our protocols and just go with what's safe for the patient? Because we certainly, in my career, have seen everything's gone more protocols than it has to make a decision based on that.
No, absolutely not. I don't think we should abandon the protocols. I think we need to use as much information as we have and as many tools as we can to make the decisions. And so use the protocols and then use, this score or whatever decision-making process you come up with and put those together to see, if they're in congruence. If they're not, then that's when you have the multidisciplinary discussion and a very detailed discussion with your patient about, what the optimal treatment plan would be for them. But I think it's both things. Yeah. I think there is room to be outside of some of our existing protocols and still be in a safe place. So, yes.
I think this is phenomenal.
Thank you.
And I'm going to free associate, which is dangerous in front of a big group. But at least the way I look at it and what you just demonstrated is somehow surgeons or tumor boards or combination with those entities with patients are apparently making some good decisions. Apparently. Now I know you're going to do all this very carefully, and you're going to have a derivation set and validation sets, all that stuff. I know you're going to do all that. But it would be nice. Now here's the association. If you could have some pre-existing hypotheses as to what the elements might be that will go into the final score you develop. And it might be, if you had some drinking buddies at tumor boards and stuff at a few other institutions, you should all get together. You could just present them scenarios and you'd say, which patient might you offer this to as opposed to others? And then you'd have some pre-existing hypotheses before you went into all the heavy-duty statistics that you're going to be doing later on. And furthermore, you'd have some, you could separate out the individuals. You could say, this is what the HEMOC people thought, and this is what the surgeons thought, and so on. Now, I don't know if does other people around the country already know about this stuff that you're doing?
Not so much, but.
That might be, from your personal standpoint, that might be good, because somebody is going to jump. I mean, I know you're going to jump on it, but you can imagine when other people see what you've already done.
Well, I actually have done what you free associated also. And I have talked to numerous patients and also providers in other disciplines about their attitudes. And I'm going to be including a qualitative component to this down the road also. So it's neat that you threw that out there. So, all right. Well, thank you all very much.